let's just say you have vision loss. Now, what do you face? And Dr. Scott Edmonds is here to tell us about that, if you would. Thank you.
Good morning, everybody. Thank you for having me here today. I wanted to just point out a few things before I start. My name's Scott Edmonds. I'm the patriarch of a family practice here at Wills. My wife and my son, we run the low vision and contact lens clinic here on the 10th floor. I really want to thank the last speaker for saying something very provocative that I've been saying here at Wills for 30 years. You notice his two slides from the last one, he said the future for eye care is in contact lens. Did you all notice that? So I'm happy to be part of the service that's part of the future for Wills in contact lens. But today specifically I'm here to talk to you about some techniques that we use to manage people with vision loss. And we're going to talk about prisms, filters, and focus. Let's first start our discussion with talking about prisms. Now everybody probably knows what a prism is. A prism is used to bend light. And if you remember from grade school, your teacher showed you a prism, which illustrates the point that we always make, that if you bend light far enough, it will break. And it breaks into its various color components. So you can take a prism, shine light through it, and the light is bent so hard that the light actually breaks out into the rainbow of color. So you often see prisms used to demonstrate the rainbow effect or to teach you that white light actually contains a series of colored lights that come together to form white light. That's not what we use the prism for in low vision. We are careful to sort of avoid that breaking of the light into its various components. But we want to bend light to be able to provide a number of services for patients. The classic use of ophthalmic prisms was for people who had double vision. If one eye is pointing here and one eye is pointing here, we can use a prism over this eye to basically bend the light so that the two images come together and people see single. So when everybody thinks about prism in eye care, they think about people who have strabismus or what we note as crossed eyes. These are crossed in or crossed out. Most of the time these are children. Sometimes it's adults that have a stroke that have double vision. So management of double vision has always been the classic application of prism. However, that's again not what we use prisms for in low vision. Prisms in low visions are used to move the images away from the damaged area of the visual system and refocus it on vital areas of vision. This is really an important fact. Most people that have vision disabilities from a number of diseases, including glaucoma, are not blind. If you're blind, then no amount of prism light or lenses is going to be effective at all in helping you. You need other non-sighted therapy, braille, cane travel, dogs, etc. But most people are not in that category. Most people have vision damage, but they still have some vision. So it's frustrating to realize that you can see things, but you can't see what you want to see. And so this is where we use the prism to move the images away from the dead zones of the eye into the areas that see. Now, in cases where people have both eyes working, we can't move the right eye up and the left eye down and expect you to function because you'll see double, and we can't move them in and out. So we have to move the eyes together. We use prism in that case over both eyes, so they move in concert away from the dead zone in the better eye. These are the three main reasons that we use prism in low vision. The first is hemianopia, which is left-sided blindness or right-sided blindness, or upper or lower-sided blindness, which are less common. But most commonly, people after a significant stroke will lose the right side of both eyes or lose the left side of both eyes, depending on where the stroke occurred. And these people are very frustrated because half their vision is very good, including their central vision, but the other half is blind. There's no vision to the left. And unfortunately, the way the visual system is wired, this stroke happens and affects both eyes, so you lose the left side out of both eyes. If you lost the left out of the one eye and the right out of the other, you could compensate. But unfortunately, the way strokes occur, you lose both. The second area is in people who have glaucomatous visual field loss, and we'll talk a little bit more about that. The third big area that we use it is in dry macular degeneration. And the new field for us to use prism is in people who have brain injuries. So we're going to talk a little bit about those areas. Let's first talk about this person who has sighted blindness. So this is a visual field test showing, as you look, the left side of the field is normal, the right side is darkened out or is blind. So this person can only see to the left. What we do for people like this is we apply a prism so that we shift the image over to the blind side. So if I look straight ahead and I can only see from straight ahead to the right, if I apply a prism in front of both eyes, I can shift my field of view, so even though I only have half, I have the central half. Now, that would sound pretty straightforward. Why don't we just always do that for people who have strokes? The problem is that when the brain goes to fixate or use the vision, the brain will use the center zone, the area that we call the macula, and it'll basically negate the prism effect. Because once you start to read or look at something or watch television, the prism is deleted because you move your eye to compensate. However, when your eye is at rest, when you're just walking around and not really looking at anything, the prism does take effect and shifts your vision from all to one side to more to the center. Now, you still are missing a 90%, but we've shifted it over so that you're seeing straight ahead. But every time you go to fixate, you're going to shift it back to the center. So this tool has been very effective for stroke victims. The amount we shift depends on how mobile the patient is. Young people with a stroke, we can shift the image over pretty far. Elderly people that have trouble with the fact that the prism shift is a bit disoriented, we have to shift it a little bit or shift it into steps. So this is the primary use for prism in stroke patients, and we use it pretty routinely in people who have a hemianopia, and we test them and do various other techniques as well. In glaucoma, we have field loss that's a little bit less regular. It's pretty easy in a stroke because it's a straight line loss, right versus left. But in glaucoma, we often have people who have sort of diffuse vision loss. But if we can identify in the visual field that this patient, and this was on this patient, this was their only eye, the other eye was actually blind. So we can see that this person has much better vision above center and virtually no vision below center. So when they go to walk around, they can't see the floor. Because all they can see is the ceiling, which really isn't all that helpful when you're walking around. You don't bump into light fixtures, but there's a lot more to bump into on the floor. So we can use a prism in this case to basically shift their vision down, so we bring this image up, the part of the visual field up here that's functioning, more into play. Again, the same problem happens when the person fixates on something. They're going to shift back up to their normal position. But when the eye is not fixating, when the eye is in what we call the primary position or the resting position, which it often is when you try to mobilize, shifting the images to the part of the eye that sees is very helpful in terms of mobility. In head trauma, we think of head trauma as somebody that's in a train wreck and has a severe brain injury or an automobile accident. We're finding out today that head trauma now can be very mild head trauma. We're seeing it in kids that play midget football. We're certainly seeing it in professional football players. We see it in college football players. The head is a very fragile organ. And when you go banging it around in sports or in other activities and you jostle the brain, you've got to have some effect. You often see people who, after even a bump on the head, are what we call dazed, and that's where they're disorganized. So when you have any kind of head trauma, you have loss of nerve conduction in the brain. The brain's careful way that it sends nerve signals all around the brain for virtually all the functions that we participate in, that impulses get scrambled. Now, your visual input is the most critical sense for the brain to be reorganized. So if I'm brain injured and I want to try to recover from this, my main area of sensory input is my vision. Hearing helps a little bit, touch, feel, all the other senses are clearly important, but the most important sense is vision. So we can work with people's visual system using prisms again to basically help them restore their binocular vision, help them control their vision movements right, left, up, and down. So we use a number of prisms. First, we use the prism to show frank double vision. People who have been brain injured often have mild double vision that comes and goes. And it's because they have a natural tendency for their eyes to drift apart, and because the brain's been scrambled, they can't control their visual motor function like they did before they were injured, and so they see intermittent double vision. And frankly, even if it's not double, the world is confused, and they're not really sure where that chair is, whether it's a foot away or 10 feet away. So by using prisms to basically bring out the double vision and then show people how to realign their vision with prisms, we can actually reorganize the brain through reestablishing these motor skills, and then through repetition. They do the same exercise over and over again, and you reestablish the way neurons flow through the brain to reconduct normal brain activity. So visual rehabilitation for people with head trauma is critical, and prisms are one of our main tools in this area. Now here's another common problem, macular degeneration. If I would have stood up here 10 years ago and talked about macular degeneration, most concerning would be the wet form or the bleeding form of macular degeneration where people would lose vision. And in those cases we use magnification as our main tool for people with the wet form. Fortunately, over the last several years, we have come up with a number of drug options that can be injected into the eye to almost eliminate the vision loss from wet macular degeneration. Again, depending on timing, if you've already had damage from wet, we can't restore that. But if we catch people early with the wet form of macular degeneration, it's very treatable with a number of today's drugs that we can inject in the eye. The problem is none of that helps the dry form. And this is a patient with dry macular degeneration. The areas that I've outlined in white here are all basically blind zones. There's the retina is damaged here, so this person doesn't have any sight or very little neurons that work in this site. But out here, the retina is pretty normal. A little bit defective up here, but here and here, this patient has pretty much normal vision. But these are not the areas that people use to be able to look at a newspaper or be able to read or watch television. The brain is trained to always use the center of the macula for vision. So we have to use prisms to shift the light from the macular area out here to the area that sees, and then we have to use magnification because the area out here is not as sensitive as the macula to be able to rehabilitate people. So in macular degeneration, we use prisms to move the images away from the dead zone onto the sighted zone, and then it requires a lot of training or what we call rehabilitation to keep people to stay out here and use this vision because their natural tendency is to go back to their old pattern of vision and use the macula. So prisms are used sometimes only in the testing and rehabilitation, and sometimes we actually grind the prism lenses right into their low vision glasses. Now, in addition to PRISM, which, as you can see, is a pretty helpful tool in a wide range of vision problems, there's always also the issue of filters. Now, filters basically screen out certain types of light. Even for the average everyday patient, filters are helpful because filters cut out glare. A lot of you that I can see have anti-reflective coating on your glasses so that it cuts out the glare and allows more light to return to the eye. But when you have vision diseases, we want to filter out more than just the reflected light. We want to filter out certain wavelengths of light. You know from anybody who's used a hearing aid, you get a hearing test and they tune certain frequencies or the ones that you can't hear, and your hearing aid gets tuned to make the frequencies you can't hear louder and the frequencies you can hear normal. So in the same way, light has frequencies, and certain wavelengths of light confuse or otherwise create glare or uncomfortable vision for people with vision disease. So we use certain filters. The 550 filter that filters out light in the 550 range is very helpful for people with retinitis pigmentosa or albinism. If we go to the 527 filters, which is a different filter, that's very good for people with diabetic retinopathy or frank photophobia or aversion to light. The 511 filter is the one that we use in macular degeneration and glaucoma. And the 511 filter is sort of a yellow color. If you see someone wearing glasses that have a yellow tint, then those people are probably wearing probably a 511, which is the most common filter we use because macular degeneration and glaucoma are the most two common diseases that we use. There's one more filter that's a new one. This is the 450 filter that seems particularly useful in patients with optic atrophy or optic nerve disease. So depending on your disease, we would apply filters to your glasses or to your low vision aid to increase your ability to see. Now, this is not as straightforward as it sounds. Even though these categories are broad, we have found only by testing you with these different filters, because some people with the disease in question have a terrible result to this recommended filter, and sometimes like one of the other filter numbers, and sometimes they don't like any filters at all. So it's really not hard and fast. Every patient with this disease gets this filter, but we certainly want to test these different filters on people that have any of these diseases or that have vision loss. Now, the last piece I want to talk about today is the importance of refractive error. Everybody knows that when you have normal sight, if you get a good pair of glasses that focus your eyes correctly, your distance vision is comfortable, your reading vision is comfortable, and life is grand other than the fact that you have to wear glasses. Now, people that have ocular disease, that same issue is there. Those people all have some type of refractive error. The problem is that normal refractive techniques with either the autorefractor or with the standard machines in your eye doctor's office, the machine that we call the phoropter, don't really work very well in people with eye disease because people can't tell the difference between the choice 1 and choice 2 that the doctor shows them. They all look the same. And so the doctor, without a correct answer to which lens is better, can't really determine your refraction. So in low vision, we use special refractive techniques, mostly done by hand, old-fashioned hand lenses. We also test people at 10 feet rather than 20 feet because it's really important that the focus be correct. So the focus is more important in ocular disease than in a healthy eye, but it's just harder to determine. So we use these special techniques, and we also even use our PRISM, again, to move the image onto the part of the eye we want to focus the light on, which is a different angle than straight ahead, and then we refract to the area of the eye that works. So refracting people with vision loss is a challenge, but it's a big thing that we do in low vision. So in conclusion, I just want to leave you with 3 points. First of all, vision impairment is not blindness. People that are visually impaired, even if you get the label legally blind, which means you get a tax advantage, it doesn't mean you're blind, and you shouldn't really just accept blindness and move on. Improved visual performance is achieved by reorganizing the way the brain uses the vision system. We do that with prisms. We do that with magnification. We do it with filters. We have to change up the environment to improve and help. And then the correct use of these all these tools will basically accelerate the rehabilitation process and get that person functioning back as close to normal as possible. And that's really what our goal in low vision is, to take someone who's not functioning and return them to the best possible function that we can attain. And with that, I'll open it up to anybody have any questions. Professor, I knew you'd have a question.
I have been over time. You have taken care of my mother, my wife, and myself. And I have always been delighted to see that you not only look at the patient, but listen to him or her before you prescribe something. I have a question on the treatment of glaucoma with drops. How long would the drops lose effect in terms of not being viable anymore? And number 2 is related. The laser, should it be used before the drops or during the drops or after the drops, or does it make a difference? Thank you.
Okay, the questions were whether or not drop therapy loses its effectiveness, and also whether or not laser treatments are applied during drops or after drops. Those questions are probably better directed to some of the other speakers here today, since that's sort of not my field, but I can quickly say that the one drop does not cure your glaucoma. You need to go regularly to have that. Drop effect does change over time. It can become less effective. So it's important for ongoing follow-up care. And the application of laser, again, is a decision between you and your surgeon about whether your treatments are effective the way they are, whether the drops are practical for your lifestyle. So those are all, again, questions that I'll defer to the expert. But basically speaking, each person that has that disease needs to work closely and regularly with their eye doctor to be sure that they have the best therapy at any given time. Another question?
At what point in your treatment does one go to you? How stable does the eye need to be before they go full? At what point in your treatment can you can you come to someone like you? Do you have to be referred by the physician?
Okay, good. That's a good question. Our question was, at what point in the process of your disease do you come to see us in low vision? The answer to that is usually best directed by your physician. Your physician who's taken care of you usually determines when they have you stable. They don't want to send you to us if you're in the middle of treatment where your visual outcome is liable to change one way or the other. Certainly they don't send you to me today and me to do all my work and then tomorrow do cataract surgery, which would totally change the field. So it's really best left to the doc. Most of our patients are referred to us by the doctors, both here at Wills and in the community, when they feel the patient is stable and also that the vision loss is permanent. We don't want to come and do all these adaptive techniques if there's some type of surgical or medicine that can improve you. We're sort of the court of last resort. Once they've got you stabilized and they feel that your vision disability is going to be permanent, then you come to us and we're going to work through all of these techniques to basically get the most out of the system. So it's best if you're referred by your regular eye doctor.
In terms of glare, which is a chronic kind of thing, can you address that in the interim while the eye is still settling down in terms of the filters?
Yes, her question was in terms of glare. We do want to apply anti-glare treatments, and a lot of times your regular doctor can prescribe anti-glare coatings on lenses. That's pretty common. But again, if your doctor feels that your question or your problems are beyond the scope of what can be done in a regular examination situation, they would usually refer you to us to work with that. The filters can be applied anytime, but we usually grind them into a new prescription, and we want to make sure that we make those glasses when you're stable and not when you're subject to change.
And thank you very much.
Okay, thank you. Thank you for your question.